Welcome to this wonderful day, August 22nd, 2026. It is an anniversary, and I'm extremely happy that so many of you came. It's unbelievable how time flew by in 5 years. I gave more than 250 lectures. Dear colleagues, it's time for champagne. I hope you can raise a glass at home. And I would very much like to thank all of you for hanging in there. I promise you a surprise present, and I have it, but I pulled in a very simple case for you, and this is an asymptomatic 55-year-old woman self-test. At this time point, you have the MLO projections very well positioned, and I'm positive that you already found asymmetric density. And even if it's not very well seen on the MLO projection, and AI is infamous about finding architectural distortion, but the disease is there. We have to react. We radiologists must say that there is nothing in this area compared to this one. And of course, we are not speculating whether it's cancer or not. We just call her back and do this. And indeed, it is a stellate lesion. And now, which one? Pure AAB with a 98% probability of surviving 25 years. The mini BCMO with the 89%, or the de-differentiated neoacinogenesis with the shy 72% survival. Radiology cannot help us. Ultrasound cannot help us. MR cannot help us. Unfortunately, in this case, we couldn't even do MR because of claustrophobia. We need to sit behind the microscope. Your self-test is going to say immediately, making me happy on this anniversary, that you know exactly whether this is the good, the bad, or the ugly. Surgery, good surgery, and the pathologist sends out the good news. It's unifocal. Here you have the caliper, no calcification, no satellites, 15 millimeter free margin. Great. This patient, unfortunately, can be overtreated. And now you look at the low, intermediate, and high power images of this histology, and you got one task. Does this look like this? No. Does this look like this? No. Does this look like this? Yes. We know that it's just a 9 by 9 millimeter unifocal, well-differentiated tubular carcinoma. She's going to get radiation and tamoxifen and whatnot. All these are unnecessary overtreatment. Node negative. She's here. About 13 years passed by, nearly 14, and she is well. That was the intro, but what I wanted to give you was the following. We talked so much about the AABs, case after case, and I just showed you one. We talked so much about the ugly one, but we didn't talk much about the middleman. I'd like to share with you an entirely new discovery. If we don't split the stellate lesions, then we have all three, the ugly, the bad, and the good, after 25 years. This is a survival. Mind you, this is an aggregate of 3 different subgroups. 2004, we published an article, and we called attention of the medical community. Stellate and circular lesions, 1 to 14 millimeter, in this case it's 1 to 9 millimeter, are extremely good. But if you add to 1 to 9 millimeter stellate lesions, casting type calcifications, then there is a significantly worse outcome. When we use this logic, without this, favorable outcome. With this, poor outcome. So, who is guilty? This one. Dear colleagues, it took 25 years before the coin dropped. We were wrong. This is not responsible alone for the poor outcome. Then what? Out of these three, 30% belong to the ugly. Only 28% die. Let's say 30% of the 30%, yes, it pulls down the 98% survival to 90, but we didn't know about it because the mammogram here and the mammogram here is the same. The epiphany is the following. This one is only de-differentiated cancer, neoduct genesis. Here, only 30% were. Here, let me be a little bit dogmatic, 100%. So wasn't this the guilty one? This stellate and only the 30% of the stellate here are identical. Most of them, even if it's microinvasion, that causes this problem. But where does the mini-BCMO come into the picture? Well, it doesn't disturb much. First of all, because it's a minority. Second, very few of them die. And that's what we are going to talk about.